Thanks, Vicky, for that humbling introduction. I mean, I still wanted to play in the NHL when I grew up, but I guess that never happened. So here I am. Hello, everyone. Pleased to be back for another year presenting our drug trends and benchmarks. As usual, being a former benefit consultant for about 15 years, I always feel the need to start with a joke, which is typically to make fun of the consultants that are widely represented at these sessions. Oh, so that reminds me of a story, actually. In a village in Africa, there was a market going on. One of the vendors was a headhunter, and a sign hung over his store. It said, ordinary brains, $10 a pound. Accountant brains, $15 a pound. Doctor's brains, $17 a pound. Consultant brains, $114 a pound. So when asked to explain the relatively high cost of consultants' brains, the headhunter said, do you have any idea how many consultants we have to catch to get a pound of brains? I know, very funny. Actually, if I was still consulting, the cost may even be higher, given I would be adding even less brains to the mix. So there's that. Okay, next slide, there we go. So today we're going to review some of the mainstays of our annual trend analysis, as well as the addition of some new data sets we're going to bring into the mix. The session is going to start with a review of our key results and on to drug utilization. We will then focus on high cost claimants and their share of cost and risk, followed by analysis of the often overlooked dispensing fees. We will touch again on the pandemic impact, then conclude with our usual therapy class analysis and plan design trends. So on to the terminology. So every year we level set the audience on the terminology just to ensure everyone better understands what the numbers actually represent. So terms like insured, certificate, cardholder, claimant, plan member, often these are used interchangeably and can be quite confusing. So for the purpose of this session, insured will be the total number of distinct individuals covered during the period, regardless if they claimed or not, and regardless if they are the employee, spouse, or dependent, so anyone that's covered. A certificate is one count that covers employees and all their linked dependents, so everything rolling up under a certificate. Also, to neutralize the plan design differences, the majority of the analysis will focus on eligible costs, so the cost before any plan design features like co-insurance and deductible, et cetera, are applied. And please note that the statistics I'm going to present may differ significantly from your plans you manage or administer, so use caution when making any comparisons. The coverage level of plan, demographic composition, provincial program coordination, even industry can impact costs. So keep in mind while we are reviewing the individual results. A plan renewal is a prospective exercise where what we're looking at is retrospective. So for relevance, we're going to share the size of our book of business used in our analysis. As you can see, our book of business is growing outside of Ontario, with key partnerships such as Desjardins Insurance joining TELUS Health in 2021. Although Desjardins will be excluded from the subsequent slide numbers, as we do not have year-over-year history for them in analysis as of yet. Our total certificate count is much higher than the numbers seen here, but we exclude the federal PSHCP plan and also the provincial workers' compensation drug claims reprocessed, as they are not true drug plans, but rather drug claims processed that are related to the occupational injury or illness. In total, at the end of 2021, we covered nearly 16 million insureds and processed over 160 million total claim transactions. However, this analysis today will focus on a subset of the given groups excluded as noted. So on to key results. The average eligible monthly cost per insured across Canada was $43.56 nationally. The West was lowest at $31.92. However, the cost per claim on Ontario was $86.75 in 2020, and now is $96.46 in 2021. It does seem like that change in the day supply and hence quantity per claim is driving the jump. In Ontario, in 2020, pharmacies restricted fills to 30 days even for maintenance drugs. So the cost per claim was much lower given it was for 30 days only. This restriction was lifted partway through 2020, but does seem to have had a year-over-year impact. The other variable would be increased specialty drug utilization year-over-year, which would also drive eligible cost per claim upwards. Utilization significantly dropped from 2020, given 2021 was really a full 12 months of the pandemic compared to about 9.5 months in 2020. almost 5% total drop in claims volumes year over year. However, as we will see later, specialty drug utilization is actually increasing. And once again, Atlantic Canada has the highest generic fill rate at 72%, as you can see. Sorry, I guess I didn't move towards that next slide. Okay, there we are. Change in eligible monthly cost per insured. When looking at the change in monthly cost per insured, we note that at the end of 2021, we observed a 5% increase, up from 3.8% on a national basis the prior year. You may recall last year this was much higher as 2019 when we had OHIP Plus in the mix. That was repealed in Ontario. It resulted in increased cost to private plans for the under 25 in Ontario last year. Once again, Quebec had the highest increase at 6%. As you will see later, this is largely attributed to both higher percentage of and higher year-over-year growth of specialty drugs that we're going to get into. So we see here the cost per claim increased significantly across all regions, most notably in Ontario with an 11.2% increase year over year. This can be partly attributed to the return to a full year in 2021 of maintenance medications being submitted in longer day supply. Obviously, that's going to increase your average cost per claim because of higher quantities. But as you likely know, and we'll see later, in Ontario during the initial months of COVID, maintenance claims were limited to that 30-day supply to protect against shortages and hoarding. So that certainly meant that the lower cost per claim than normal in 2020 compared to when we look at the 2021 numbers. So as we're going to see later, specialty and drugs to treat rare disease are also on the rise, which contributes to year-over-year cost per claim growth. On a national basis, the cost per claim increased 8.9%, which is far above general inflation. So in comparison, CPI increased about 3.4% in 2021. On the other hand, keeping rising cost per claim in check is the reduction in utilization in 2021 from the prior year. So 2021 saw further reduced utilization, again, probably given a full 12 months of the pandemic influence these claiming patterns versus, as I mentioned before, is about 9.5 months. Nationally, the drop was about 3.5%, but Ontario saw the highest reduction at 5.6%. Quebec, on the other hand, kind of remained relatively flat, as you see. So let's look at the components of trend now. As we saw earlier, overall trend increased 5% year over year for all drugs. However, growth in specialty drug costs continues to far surpass the growth in traditional drugs at 9.5% compared to just 2.9% for non-specialty or traditional drugs. Last year's specialty drug trend was 8.7%, so it's going up, as you can see. As you'll see later, specialty drugs continue to grow as a percentage of overall plan costs, although only fueled by a small percentage of claimants. So when we calculate annual trend or year-over-year growth, it's the change in utilization per insured and the average cost per claim. Change in the average cost per claim. So to dig deeper into the components of trend, we see that overall, it is the large increase in cost per claim that is contributing the most to the year-over-year increase of 5%. Again, utilization appears to be lower given the pandemic, but the average cost per claim has increased given increased specialty growth, but also having maintenance claims once again being submitted in a 90-day supply across the full year of 2021. Once again, specialty drug utilization has increased far greater than traditional drugs. Specialty drug utilization can be considered more pandemic-proof than traditional drug usage that may have been foregone due to the COVID pandemic. As newer, more novel therapies come to market that now treat previously untreated or undertreated diseases, we will more than likely continue to see increased utilization of these breakthrough products. Well, looking at age bands, so we know drug benefit costs increase as we age. What may not be well known is the magnitude of the increase. We will see here the monthly cost of 60 to 64-year age are approaching 7 times that of the under 25-year-old. Younger people typically are claiming more acute therapies, which are generally low cost, but as we age, chronic conditions emerge. Often we see as people get older, they're treated for several conditions such as type 2 diabetes, hypertension, elevated cholesterol, possibly mental health, and even pain management. This will become more evident when we look at the percentage of claimants by disease and age band later on. Continue with age-based statistics. We see that when we compare to the previous year, the highest cost increase was actually in the 20 to 30, 39 age band, or sorry, the 30 to 39 age band. You will see later in therapy class rankings, there has been some movement in the age group towards higher utilization of depression drugs, which are a little more expensive than the lower cost acute therapies typically seen in this age bracket. Similar to last year, the oldest age band witnessed the lowest cost growth. However, as per the prior slide, this age group is by far the costliest of insureds under private plans. Okay, on to drug type utilization. We showed earlier on in our key statistics that the fill rate for 2021 across our book was 66% on a national basis. However, there are some differences by regional, as you can see here. Atlantic Canada continues to have the highest generic utilization, now at 72% in 2021. Ontario had the lowest, with 63% of claims being filled for a generic. Quebec has steadily grown its generic fill rate since the RAMQ do not sub changes were introduced back in 2015. And as you can see, just kind of the beginning of 2016, we're showing in the slide. Prior to that, Quebec historically had the lowest generic fill rates. So multi-source brand utilization. So this is when a brand drug is dispensed, but there was a generic interchangeable equivalent on the market at the time. So it's highest in Quebec at 9%, despite a 2% increase in generic utilization in Quebec we saw on the prior slide. So hence there was a reduction in single source brand drug utilization in 2021 across Quebec as well. Now, keep in mind these numbers are based on the drug dispense, so plans that have a mandatory generic substitution plan design would have only paid up the generic equivalent price in most instances. So continuing with utilization by the different drug types year over year, we really see nominal increases in the percentage of claims dispensed for generic drugs. In 2021, we did observe a 2% uptick in generic claims. Now we're at that 66%. Branded claims, either single or multi-source combined, account for the other 34% of claims dispensed. It's actually down from 36% year to year. So every year we're seeing slow progression towards increased generic utilization. From a cost perspective, when we look at the eligible amount by type of drug, single source brand drugs continue to dominate the percentage of overall eligible amount paid. Yet these have dropped from 71% to 69% of total eligible amounts nationally. The cost for generic drugs still account for less than a quarter of the total eligible amounts, even though we saw the prior slide, 3/4 of the claims are dispensed for generics. Okay, let's move on to specialty and biosimilar drug analysis. So talk about some definitions. Like most PBMs and insurers, we define a specialty drug as any drug with an annual treatment cost over $10,000 a year. This applies to both biologics, biosimilars, and even in some rare cases, small molecule drugs. They typically require special handling and administration as well. So although high cost, these breakthrough drugs are changing the way we treat serious and very rare conditions. Okay, so now at 34%, we see specialty drug costs exceeding 1/3 of total drug costs. So coming from that 1.4% of claimants. The number of claimants being treated also continues to increase as we see signs of broadening utilization of specialty drugs as a result of new specialty drug classes being introduced. The percentage of specialty drug spending has increased significantly since 2008, and based on the current pipeline, this percentage is expected to persist. Too far ahead, sorry. So the percentage of specialty drugs costs has increased across all the regions, as you see, and has since 2008, as we're showing. However, Atlantic Canada continues to lead the way at 41% of all eligible amounts attributed to these higher cost specialty drugs. Many are very high cost drugs to treat rare disease. Atlantic Canada has a disproportionate share of high-cost genetic replacement therapy drugs that seems to be propelling overall specialty drug costs year after year in that region. Yeah, you also note the Western provinces continue to see lower specialty drug costs for a couple of reasons. Provincial pharmacare integration programs are paying part of the cost, as well as the newer policies to promote lower cost biosimilar drugs, which we're going to focus on later when we compare biologic and biosimilar utilization and cost in British Columbia compared to the rest of Canada. So you'll see here the total monthly cost per certificate in 2021 was about $100. That was made of about 2/3 non-specialty drugs. You see the $66 for non-specialty. However, each year, new high-cost drugs indicated for rare disease, as well as expanded utilization of existing specialty drugs, are driving exposure. As you can see, the green line moving from $22 monthly cost per certificate up to $34, what we're sitting at in 2021. And again, that's only from a small percentage of claimants. So as we saw on the previous slide, the growth in percentage of claimants using specialty drugs is becoming a significant factor driving overall costs. Looking at the compounded annual growth rate of the percentage of claimants on specialty drugs, it's growing higher than the growth in the percentage of specialty costs over the last 5 years. So utilization is becoming a much more significant factor as there are more specialty drugs coming to market to treat these types of diseases. The compound annual growth rate of the percentage of claimants was 8.8% over the past 5 years, compared to 5.9% was the percentage growth in costs over that same 5-year period. So if we're just to use the basic Excel growth function, which we've done here, it's not anything beyond that. But if the trend continues, we could see the monthly cost per certificate for specialty drugs equal that of non-specialty drugs by 2026. So that's only 5 years from now. Okay, so we're looking at the specialty versus traditional drug split. We're going to get into more details on the overall top categories with respect to rankings later. But what is displayed here is the top 7 categories based on percent of eligible amount. So to gain a perspective on what is driving costs within these categories, we need to look at the drug composition of the therapy class. So for example, you see here the rheumatoid arthritis category is almost entirely made up of specialty drug costs, whether they be biologics or the more recently launched biosimilars in this class. However, the diabetes class does not have any true specialty drugs when we define them as over $10,000 per claimant per year, but the introduction of newer, more effective diabetes drugs replacing more traditional treatments are driving costs in this category. That combined with more widespread utilization as more and more people are diagnosed with type 2 diabetes. The cancer class is also seeing higher concentration of specialty drug costs given the new advances in this area. Also, there are several pipeline specialty drugs coming to market to treat various forms of cancer. Okay, so let's look at the change in eligible monthly costs for specialty drugs. So Quebec saw the highest increase in eligible amount per insured at 11.3%, followed by Ontario 10.2%, and then Atlantic Canada is 9.1%. And they obviously had the highest percentage of specialty eligible amounts on it in that the region. So the relatively low rate of 6.7% in Western Canada again reflects pharmacare as well as some of the switching programs that have come into effect. So Quebec had the highest proportion of claimants being treated for drugs for rare disease. So when you kind of peel back the layers of the onion, we saw considerable ultra high cost drug usage of over $100,000 annually per claimant in Quebec, going up year over year. So claims for rare disease such as Soliris and Vimizim and several cystic fibrosis drugs had material increases in 2021, which factor into the larger overall specialty class growth for the Quebec region. With this in mind, it will be interesting to see what progress can be made on a national strategy for drugs to treat rare disease. So, I mean, that's been in the news for a couple of years. At this point, nothing more than stakeholder consultation has happened on this front. Also, there's thousands of rare diseases that do not have any treatment options available at this point. So we can expect continued advancement in developing therapies for these rare diseases. Okay, on to biosimilars. When we look at biosimilar cost distribution outside of BC, we see, and we showed this last year, we've extended it another 12 months, we see that there has not been much movement towards biosimilars, accounting for just 12% of costs by December 2021. So this percentage represents the proportion of costs associated with the biosimilars where there was a biosimilar available in place of the innovator biologics. It's just so we're clear on what this represents. But if you look at BC, it's a totally different story. It continues to grow its share of biosimilars given the switching policy that has been implemented. More recently, other provinces have enacted various forms of biosimilar policies, which we are monitoring and will report the impact once more data is available. Looking at relative cost per claimant, and again, we showed this the prior year, but we're just extending it and showing where the linear trend's actually moving to. You can see the impact of BC's policy has on cost per claimant using January 2019 as the baseline before the introduction of the switching policy. The relative cost per claimant in BC reduced to about 2/3 of its baseline cost by the end of 2021, so 66% biosimilars cost in that category. In comparison, outside of BC, the relative cost per claimant has increased 10% since 2019. So it's growing outside of BC, but again, there isn't as many just more recently introduced non-medical switching policies we're seeing in the other provinces, which is why we're probably not seeing the adoption rate. Okay, now before we get into the high cost claimant analysis, it's time for our first polling question. Question is, 98% of claimants have a total annual eligible amount less than $10,000. What percentage of total eligible amount do the remaining 2% over that $10,000 annual represent? Is it 20%, 40%, 60%? Okay, so the results are in. I can't really see them very well with my glasses and my eyes, but the answer is 40%. So those of you that got it right, congratulations, you're on the ball today for the first of our polling anyways. Okay, so let's get to the next slide. So here you go, 2% accounts for about 40% of the total eligible amount. So that 98% under 10K, 61%, and then the rest is at 39-ish percent. So this year we're providing a look into the impact of high cost claimants have on total drug spend. The large majority of claimants have annual eligible amounts below $10,000, as you can see. In fact, the average annual cost per claimant is only about it's about $928 across 2021 if you look at everybody combined. However, the 2% of claimants with annual eligible amount above 10K account for that 40%. What's even more alarming is that nearly 6% of total eligible amount is coming from just 0.03% of all claimants. These are the claimants that are on ultra high cost drugs to treat very rare disease. So you see with this slide that the proportion of total eligible amount for claimants with less than 10K is actually decreasing since 2017. The inverse is happening for claimants over 10K if you look to the right hand side on the eligible amount. In fact, nearly 6% of eligible amount coming for those claimants with over 100K that we showed earlier has nearly doubled since 2017, which is adding 2.1% to that cohort's total eligible amount. As indicating earlier, these costs are a result of a newer high cost therapies to treat very rare diseases being developed. So if we look at the disease profile of these high cost claimants over 100,000, This view here breaks down the types of conditions prevalent in those claimants that have that over $100,000 cost per annual cost per insured. The highest percentage of claimants falls under the antibiotic category. So as we know, these are typically very low cost acute therapies and are really not driving the cost. Yet you can see from the green line represented that both cancer and rheumatoid arthritis are accounted for a very large percentage of the total eligible amounts for those with annual amounts greater than $100,000. Of note, which is not on the slide because only 12% of claimants have this condition prevalent, is cystic fibrosis. So this accounts for about 20% of the costs of those claimants that have greater than $100,000 in annual eligible amounts. Comorbidity is also a factor. As you can see here, claimants in this cohort with over 100,000 in eligible amounts annually have on average, 6 conditions being treated. When tracking high-cost claimants over time, we observed that about half of the total claimants that exceeded 100K in 2020 also did so in 2021. What is more significant is the fact that the other 50% that were under $100,000 in 2020 have now moved over 100,000 in 2021. So it seems several claimants from the prior year have progressed in their treatment, moving them into this ultra high cost claimant category that we've been displaying. Okay, let's move on to the dispensing fee analysis. So we're looking at submitted dispensing fee bands here. So often the dispensing fees are overlooked, but they can contribute quite a bit to the cost and make up a meaningful amount of the overall entire eligible cost per claim. In fact, based on our average dispensing fee submitted in 2021 and our average eligible cost per claim, dispensing fees actually accounted for nearly 15% of the total. You can see in this chart that the large majority of claims volume is submitted with a dispensing fee in the $11 to $11.99 range. The other thing that's important to note is some provinces have set dispensing fee schedules that influence these numbers, obviously. Example, Alberta has provincially regulated dispensing fees that's now is up to $12.15. So you'll see out of that province, you'll see almost all of them submit at $12.15. Okay, let's get to another polling question before we get to the next slide. Which pharmacy type has the lowest dispensing fees? Is it large chains, banner pharmacies? Is it virtual mail order pharmacies? Or is it independent pharmacies? Okay. Those who said, and overwhelmingly the response was, virtual mail order pharmacies. So a fair bit lower at averaging 864 submitted versus chains and banners. So you see here, large banners and chains have the highest claims volume, also the highest average submitted dispensing fee at 1182. Virtual pharmacies virtual pharmacies have the lowest at 864, independent at 1147, but virtual pharmacies have much lower, volume of claims, only 0.2% of claim volume submitted through virtual pharmacies. Lower volumes at independents as well, obviously, because they're typically smaller rural areas. They don't get the volume of some of the chains. All right, if we're going to break it down by region, we're going to see nominal increases over the last 5-year period. As mentioned previously, some provinces have regulated dispensing fees that impact the average in those regions. Also, we have included Quebec in this analysis, although as many of you know, they do not separate the ingredient cost portion of the claim from the dispensing fee that they're submitting. So our system does apply a calculation, looks at the ingredient cost of the claim being submitted, adds a reasonable markup, and then assumes the remainder is a dispensing fee. So as you can see, even with that, the Quebec nets out to a much higher dispensing fee than other regions. On that note, there are amendments to the Act respecting prescription drug insurance in Quebec that will require Quebec pharmacies to submit the ingredient costs separately from the dispensing fee to PBMs and insurers So currently it's submitted to the patient, but not to the PBMs and insurers. But for that to happen, there needs to be some work done to the current CPHA standard. So this change will or may facilitate greater controls over the dispensing fees payable under plans that are in Quebec. Okay, so we're going to move on to the COVID-19 impact in the next section. We presented a similar chart last year. This one just extends at 12 months, noting that the dispensing of maintenance medications in longer day supply continues to rate at the rate of pre-pandemic levels that you're seeing now across 2021. You'll recall that maintenance medication volumes were higher from March to June, as that typical 3-month supply of medications were dispensed in 1-month supply due to pharmacy restrictions. In similar vein, the average day supply for maintenance medication dropped to about 30 days supply because of these restrictions. So you can see the line at the top that dips significantly down to about 30 in April. When these restrictions were lifted in about June, we saw 2020, we saw the increase in day supply and maintenance medications going back to pre-pandemic levels. Something else we wanted to look into is, what does this mean by not having, people regularly seeing a doctor for certain things? So we're going to look at new claimants on certain disease categories. As you can see, the percentage of new claimants being treated for depression actually dropped in 2020. Potentially due to lack of diagnosis opportunity. No one was really going to see a doctor, and because of that, they're probably obviously not getting referred to a specialist or a psychiatrist in this case, if necessary. So further illustrating this point, we see in the pink highlighted area that during the early months of the pandemic in 2020, there are much fewer new claimants in the depression category. So that's the green line you're going to see there. But you do see that green line's on the rise in 2021 when people started visiting their physicians and going and maybe getting referred to psychologists, psychiatrists. So also the overall claimants being treated for depression rises as well. If you look at the purple bars, last year we started to see the rise in depression after onset of the pandemic, as many people had feelings of isolation and even fear. So you may recall last year, claims for drugs to treat depression increased by 10% for adults and by 22% for dependents in 2020. Similarly, this chart's going to indicate that cancer is another category that witnessed fewer new claimants during the first year of the pandemic. I don't know if we're going to continue to say how many years, but hopefully it's on the end. Anyways, the percentage of new claimants in the cancer category dropped in 2020, potentially, again, due to lack of diagnosis opportunity. Things like cancer screenings were put off by patients. We know that. There have been canceled or delayed mammograms, pap tests, colonoscopies during the pandemic, and now we're seeing a backlog of these screenings, which may lead to increased new claimants in 2022 and beyond once they get diagnosed. So what we're also observing in our claims data is consistent with different studies published regarding what is being called the shadow pandemic. So during studies, physicians have reported that patients are appearing with more advanced disease. Other studies mentioned that about half of plan members admit they avoided seeking treatment for various illnesses during the pandemic. So again, later detection, backlogs for bringing people in, may have or will most likely have a spillover effect for years to come. And like the depression slide, we're showing, highlighting the month by month, the period where we did see a steadily decrease of new claimants being into our system, but then it picks up certainly after that point. Okay, now onto the therapy category analysis. When comparing our top therapy categories year over year, little change in the rankings and the corresponding percent of eligible amount from 2020. In the table, you will see those categories that have increased in rank are going to show as a red upwards arrow, while those that decrease show a green downward arrow. Equal sign, I don't have to really explain that to you. So like last year, the RA class is #1 rank by cost, and mainly this because of the high cost specialty drugs. However, the diabetes category is closing in given growth in new therapies and more widely used devices that promote improved blood glucose monitoring, as you'll see in the next slide. The ADHD category is increasing potentially as a result, and I'm not sure that this is scientific, but parents working from home along with their children that are being homeschooled. So I don't think it's unrealistic to think that parents observe the struggles with focusing and concentration the children may have experienced when placed in an online schooling environment. That could be a factor. It's logical that it is a factor on increased diagnosis of ADHD. We're seeing some ADHD drugs in the top 10, as we'll show in the next slide. Cancer dropped here probably because of the appointments in COVID. Could have been the reason for that. Okay, so top 10 products by eligible amount. At the individual drug level, there actually are several changes over last year. The biggest mover seems to be in the diabetes class, with Ozempic and Jardiance accelerating up the rankings. As usual, the list is dominated by higher cost specialty drugs. These 10 products are approaching a quarter of total eligible amount under a book of business. It's not quite a quarter, it's 21 some percent, but it's getting there. So I'm not going to spend a lot of time on these because different therapy classes will be discussed in much more detail next week at our medication management session. So in segmenting adults, utilization has decreased across many common categories compared to 2020. However, there are a few increases for categories that may be a bit more pandemic proof, such as cystic fibrosis and infertility. Those categories that decrease utilization are more related to chronic conditions. What is interesting to note is though the decrease in utilization of vaccines. I mean, it's significant, as you see on here. This could signify that people had less faith in vaccines given the COVID misinformation that has been spread. Yet also, some of these travel vaccines, some of them are travel vaccines in that category. And we know there was very limited travel happening in 2020. So I believe that's an additional factor in the drop. When we look at the younger people cohort, so dependents, like last year, we're seeing strong increases in utilization to treat depression for these younger people. Also seeing that large jump in ADH claimants, which could be a result of what I mentioned previously. Again, significant drop in vaccines for dependent children. So the next few slides compare rankings over a 5-year period from 2017 to 2021 for various age cohorts. These stats are based on the number of claimants, not costs, so just keep that in mind. We typically see claims for antibiotics, asthma, allergies, ADHD in the younger generation. But it is worth noting that percentage of claimants on the ADHD drugs is now over 13%, now ranks amongst the top 5, which it wasn't a year in 2017. You see it was ranked number 8. Moving on to 20 to 39, products more relative to that cohort appear, such as birth control. Not much movement overall here, though, although it is of note that depression has gone from 7th rank in 2016 to 5th rank in 2017, now 3rd rank in 5 years later in 2021. Again, we've seen steady growth in depression treatment, particularly in younger people, partly given efforts to reduce stigma around seeking treatment for mental health. Now in the 40 to 59 age group, as we get older, we start to see more age-related conditions emerge, particularly for blood pressure and even ulcers, as well as pain management. Biggest change in the 5-year period across this group is once again that depression category. So you can see by the last 3 slides, the prevalence of treatments is largely related to the age, although there are some common drug categories that are more broadly utilized across all different age groups. Okay, so now we're going to move to the next section on adherence. But before that, it's time for another polling session. Okay, so has adherence rates to 4 common chronic conditions improved, worsened, or pretty much remain the same. Okay, so looks like most people are saying it worsened. Actually, that's not the case. We're actually improving, which may seem surprising, but if we look at the trend across the most 5 recent year period and also look at that 2020 pandemic year to current 2021, we are seeing the adherence rates actually improving. We're showing non-adherence rate here, so non-adherence rates actually reducing. So it's possible that the 2020 numbers were impacted by those changes in the day supply limits, what we mentioned earlier. So it's possible that claimants who were used to filling claims every 3 months may not have been on top of getting these refills every 30 days, which could have led to later refills. So regardless of the reason, it's encouraging to see adherence rates are improving year over year. So when I saw that all of a sudden they were getting worse and then they're getting better, I was wondering, I'm a curious person, why? So I looked at those claimants that were in both years' data sets where we measured their medication possession ratio, so their adherence levels. So we wanted to see whether, is it across the board everybody's improving, or is it a mix? So here you can see there's not a blanket improvement in adherence. When following the same claimant year over year, though, we note there are still significant levels of non-adherence in the purple bar. But in fact, some categories, over 20% of claimants had worse adherence metrics year over year, but higher percentage of claimants improved their medication adherence year over year, which once again is encouraging. Okay, we're going to finish off this last section on plan design trends. Based on our book of business plan design data, 88% of all insurers fall under a plan with either regular or mandatory generic substitution. So that's the same percentage we had last year. Difference between these two substitution types, just so we're all clear, is regular will allow a physician to override by writing do not substitute or dispense as written on the claim, and that claim will still pay the brand price. But if it's the more strict, what we're calling mandatory generic substitution, it will only pay up to the brand. It will only pay up to the generic or the lowest cost alternative price, unless there's a medical exception form completed, which is part of the case. So a split between regular and mandatory has changed slightly, though. Now 55% in green, down from the 56% before. So again, important to note that lowest cost drugs may not always be the most effective drug for every patient. So ensuring those mechanisms for patients to continue on one drug over another is very important. On to coinsurance. So these next few slides will be based on the percent of certificates that are covered under a plan that has whatever plan design feature we're displaying. So when I look at coinsurance, not much change in the percentage of certificates that had coinsurance is now reaching 70% from 69% 5 years ago. So really not changing much. But when coinsurance applies, the most common you can see on the right is that 80%. So 20% of the out of pocket by the claimant, that's been seen as a reasonable amount for them to share in the cost and actually promote better understanding of the value of the benefit program that the employer is providing, which is very important, because if their employer pays 100%, they just walk up, get the prescription, leave, don't know anything about what the cost of the medications are. So often the claimant, even with that 80%, can be made whole through whether it be coordination of benefits with a spouse plan or through a healthcare spending account. If they have one, we're seeing those are becoming much more common these days. Okay, so annual maximums. Annual maximums still relatively rare. Now 22% of certificates covered under a plan with an annual maximum. However, you can see this has been increasing over the past 5-year period. Last year, we saw 20% of certificates covered under a plan with an annual maximum up from 18% 5 years ago. When an annual maximum applies, the most common is between, as you can see, between 2,500 and 5,000. Actually, quite low when you think about that. But we did see that our average cost per claimant is under $1,000, so they may not be impacted by this. So typically, smaller employer plans adopt these maximums because a significant impact could be for those with one or two catastrophic claimants that can be, really devastating to a smaller plan. Some plans may choose to provide a base drug benefit that has a maximum, but they may also direct funds into healthcare spending accounts where that contribution is defined. So that's another approach that we're seeing. You can see 78% of certificates are covered under a plan without any deductible at all. We know annual deductibles have been very, very low. They're eroding as far as drug costs when drug costs continue to climb. Common deductibles were that 25/50 or 50/100 single family. Those are often satisfied within the first claim of the year. So those deductibles really don't make a meaningful impact on containing cost or sharing in the cost the way a percentage-based coinsurance does. So we're seeing more of a trend towards adopting a percentage-based coinsurance instead of a fixed deductible amount, because that coinsurance is percentage-based. Obviously, it rises with inflation. So drug costs go up, the plan pays more, and member pays more. So on the right, we're showing the distribution of per-claim deductibles. Of the plans with a per-claim deductible, $5 and $2 are the most common. Again, not doing much at all to contain costs, with our average eligible amount per claim of $83.45 we talked about at the beginning. So a fixed $5 per claim results in only 6% cost share. So something to think about. Dispensing fee caps. Percentage of certificates covered under a plan with a dispensing fee cap has remained pretty stable over that 5-year period, the last 5 years. On the right, you can also see that the distribution of those plans that do have a dispensing fee cap has followed a similar distribution in the 5-year period. Most common caps are up to $8, as you can see at the bottom there, up to $7.99. So based on average submitted dispensing fees we shared earlier, an $8 cap could shift about $3 or more on average to the member. However, if making use of virtual pharmacy with lower dispensing fees, the member may not be impacted at all by a cap such as that. Prior authorization. So this means a subset of drugs on the formulary require the patient to meet certain criteria, clinical guidelines before they're approved. Most plans have had this as a standard, but the drugs subject to prior authorization may differ from plan to plan. We see here that 84% of certificates are covered under a plan that has prior authorization for at least one drug. As more and more novel drug therapies come to market, prior authorization allows for a review to ensure it is right for that particular patient at the right time based on their medical evidence. Okay, now to quickly summarize this whirlwind tour we've been on. Monthly eligible amount per insured saw that 5% increase over last year, which is higher than the year before. This increase was a result of higher average cost per claim as utilization per insured actually decreased. Specialty drugs costs continue to rise at a very high pace, trending 9.5% in monthly cost per insured year over year, higher than last year's increase of 8.7%. So specialty drugs now account for 34%, and claimant exposure is actually increasing, as we talked about. Over the past 5 years, the number of claimants on specialty drugs is increasing at a higher rate than the annual growth in eligible amount of specialty drugs. We also continue to see much higher biosimilar usage in BC, given the publicly policy that's been implemented. However, too soon to tell the impact other provinces will have that more recently have introduced non-medical switching policies. And we saw the claimants with over 10,000 in eligible amount per year accounted for 40% of total eligible amount. Even more astonishing, the very small percentage of claimants on ultra high cost drugs to treat rare disease account for 6% of total eligible amount across our book. Submitted dispensing fees now average 11.76 per claim, yet differ by province. Virtual pharmacy adoption is low, but dispensing fees are much lower, and adherence may be improved through virtual pharmacies through the reminder process, medication reminders, and also members really taking more active ownership of their prescriptions. The pandemic continues to impact utilization, and certain diseases like cancer and depression may have seen delays in diagnosis and subsequent treatment. And lastly, chronic conditions combined with high cost treatments for more rare disease dominate that top drug class profile and will continue to do so as more specialty drugs and advanced treatment options for diabetes emerge. And with that, thanks for your time this afternoon, and I'm now happy to open it up to questions.
Thank you, Shawn, for your informative presentation. It's now time for our Q&A session. Just a quick reminder to everyone, if you'd like to ask a question, we invite you to submit your question through the Q&A panel accessible on the right side of your window. Okay, so our first question, what impact will PMPRB reform have on private drug plan costs, if any?
Well, it'll remain to be seen. We know it's going to obviously it's expected to lower the cost of new drugs, new patented medicines when they're being, when the drug costs being established. And that's solely because of the different basket of countries that are going to be measured against than was before. So that we expect will happen. There's a whole bunch of other changes that were to happen that we're not sure if they're going to happen, but it seems that they're going to go together. They're going to move forward with the different basket of countries that are used for the median drugs. So given that, it's expected that the listing cost of the new patented drugs may be lower than they would have been if they were compared against the smaller subset and different subset of countries that they had been in the past.
Okay, thanks, Shawn. So the next question, what is the distinction between generic and biosimilar uptake? And the second part of that question is, what did biosimilar uptake look like across the country?
Okay, so biosimilars are not generics per se. They're not a bioequivalent copy of a chemical copy, which is what a generic is to its reference brand, because it's as much as the process of a biologic that's patented versus the composition of that drug. So they are different. They can't be considered really interchangeable, but they are, through studies, are showing to produce similar effects at lower cost. So we haven't seen, and we did look into bringing in information on other provinces rather than BC this year, but the data didn't support that there has been any kind of material shift towards biosimilar uptake in the other provinces because their policies are more newly introduced and they're going to be staggered with, there's a transition period and things like that. So certainly something that we're going to be measuring over the course of this year, and we'll be presenting more of that next year's conference.
Okay, so you answered a little bit of this next question already, but again, related to biosimilars, have the provincial policies made a difference in 2021 over 2020? And what are some of the expected future trends?
It seems to be, when you look at where we looked at BC versus the rest of Canada, and we looked at the relative costs, it's certainly there's a change in that province. There are more and more specialty drugs that are innovators, will be under patent, that are coming to market. So we expect the costs will continue to rise, but there will be maybe a blunting of it as more biosimilars are substituted for those older biologic drugs, and that should help fund the newer therapies coming to market that are much needed as well. So I think we are seeing it in BC, and we'll probably see it. But again, you can just see from history what seems to be happening with specialty drugs. They are very expensive because we know the manufacturing process is so complex. They're spread across such a small population base. So they're going to come at a high cost, but there's something that we never really had before. So the idea is, I think, is to try to find a balance between biosimilars where possible and making sure that there can still be innovation for the specialty drugs in the pipeline that are come to market that treat these rare diseases that have never even had an option.
Okay, thank you, Shawn. So the next question is, TELUS has done an excellent job reviewing the utilization and costs of drugs over the years. Is there a plan to integrate a potential measure of quality of life per certificate? Something high level that really tests the value offered per year?
It's tough to do that with the data we have, but as most people know, quality is one of the components of drug submissions and deciding whether a drug does go on, a managed formulary versus an open formulary or gets listing altogether. I think, and I'd love if we got to a point where, we're using our drug data to integrate with absence disability data, hospitalization data. There is EMR data that we technically have access to, but we don't really have access to because of privacy rights. And I'm speaking to TELUS specifically, but there does have to be a move towards a more holistic view of all these data points that we're sitting on, but they are still fairly siloed. We're making waves towards that, but yeah, I do think that if you want to talk about quality of life here, there's a whole bunch of components there that we don't have access here with TELUS, but we would be certainly interested in partnering on studies such as that for sure.
So the next question is the rheumatoid arthritis category based on the actual indication, or is it assumed that biologic therapies just such as Humira and Remicade are used for RA, even though it is possible that they might be treating another indication like Crohn's?
Yeah, and that's a limitation that we're all aware of. The way we categorize it is the first indication. But when we look at our biosimilar reference-based pricing initiative we do look at the indication coming in with the SNOMED code that can be used. So, but the data we're showing here is simply the DIN has to be indicated as one or the other. Multiple indications doesn't really work. The only other way to do that is make an assumption of 30% of the 30 cents on the dollar for this condition and not 70% on that, but that gets a little subjective as well. So it's not. It's based on the first indication of the drug that gets classified. And I do believe, and Vicky probably knows this better than I do as the pharmacy team, that I think they are reviewed definitely from time to time. And there may be a determination of a switch from something that we might have called Crohn's disease to something that we might call skin disorders versus RA. So those are kind of the three.
Yeah, you got it there. It's usually the first indication that comes through. So I'll flip to the next question. Has the mix of plan sponsors who participate in managed formularies shifted in TELUS's block over the last couple of years?
Our block is very fluid, as many people know. We're bringing on new carriers and are continuing to do so. And so we are still seeing a very slow progression, though, towards managed formularies. Often it's an open formulary. For the large majority, it's an open formulary. I expect that will change. I mean, the open formularies even aren't truly open when you consider there are administrative rules such as prior authorization that are being applied and things like that, right? So, but it is slowly progressing that way, but nowhere near what the experience in the US you're seeing is. So I think it's coming to a time where there needs to be increased adoption and really thorough and rigorous review of the new drugs coming to market to decide their place in therapy. because it's not just cost, right? The whole analysis is cost effectiveness. So if it costs a lot more, it may be way more effective. So it may mean it should be on a managed formulary than off. So that's a whole other area that I'm not involved in. Daria is on our pharmacy team, but yeah, I do see that there's going to be more movement towards managed formularies, but it, as you've seen in our different presentations over the years, very slow adoption.
That's great. So next question is, on the top categories by number of claims per insured adults, the largest growth was in weight control. What is driving this?
It's a good question. I mean, assuming on healthier lifestyles and people looking to, and that wouldn't include some of the newer diabetes drugs that are actually can be used for weight control. So it's hard to really say from the data what's driving it, but certainly it's increased over the prior period. And who knows, the first year of the pandemic, maybe we weren't living as healthy as we could be. So there's a lot of speculation, but unfortunately, really can't pinpoint it.
Yeah, that's fair. The next question is still related to sort of weight control anti-obesity meds. So do you have a sense of what percent of plans have anti-obesity meds covered?
I don't know. There's certain carriers that have a carrier exception to provide it for their entire book. There's other carriers and formularies that exclude it. Again, the debate would be, maintaining someone's healthy BMI can help lower costs in so many other different areas. So it's something to consider. To that fact, there's a lot of legacy maximums and exclusions on things that really didn't make a lot of sense, like smoking cessation. Those were set back when it was just the NRTs and not the more effective drug therapies now. So there's a lot of that stuff that's happened in the past that's worth opening up some of those contracts for plan sponsors and having a look. Does this really make sense? Are we trying to promote health and wellness, yet our drug benefit plan contradicts that in some ways?
Right, thanks. Next question is, with the increase in certificates with plan maximums, would you be able to look at paid amounts versus eligible amounts, assuming the total eligible amount would be captured in a claim that hits a plan maximum?
Yes. So the eligible amount is before any maximums. So you have the submitted amount that is subject to the price filed on the eligible amount. And then potentially up to the eligible amount would be paid until you hit that maximum, and it may be zero if you've already hit the maximum before. So yeah, those things that data is available.
Okay. So the next question is geared toward prior authorization. What do you think is causing the percent of certificates with prior authorization to decrease?
I don't really know. Again, we don't administer the coverage per se. It's through the carriers, but different composition in our book of business could be a reason for that. At one point, you may recall there were a lot of drugs that were under PA, and some of them were for off-label use. If you think of, things like Wellbutrin, which is Zyban. So again, I mentioned earlier, smoking cessation has maximums or lifetime maximums. So you exceed that, and then you go and use Wellbutrin instead. And there was some of those off-label use technically of drugs that were subject to PA, but aren't anymore because they're really they're not very high cost. So I think the idea was there wasn't really the need. So that may have changed things, but by and large, plans almost always will have, a subset of drugs under prior authorization, even though it does seem to be reducing.
Okay. Did TELUS note any increase in termination of coverage over the pandemic?
We did see that, and there were other studies that saw that as well. I know some of the consulting firms published all that, definitely. And there was reduced claims, as we saw in our claims analysis. So coverage, again, is separate from claims. We're adjudicating the claims, and coverage is something that's administered with the plan sponsor and the carriers. But certainly, I think, and CLHIA had presented that fact as well, that there certainly was loss of coverage during the pandemic, because frankly, businesses closed a lot of the time, and even if they didn't, they were struggling. And one of the ways around that was to eliminate benefit coverage.
Mm-hmm. So Shawn, I think there was a point in your presentation where one of the slides weren't showing on the screen. So the question is around that slide. If the slide shows eligible costs per insured, do you have the eligible cost per certificate?
I think that slide only shows the eligible cost per insured.
Okay.
That's what we based everything on.
It's fair. Okay, so next question. Regarding the trends in top categories by number of claims per insured, have the fertility disorders increased from last year?
I don't believe it was in our top 10 at all. Sorry, what was the question?
Regarding the trends in top categories by number of claims per insured, have the fertility disorders increased from last year?
That was not part of our analysis.
Okay.
So no, I can't comment on
Okay.
that.
How do small groups manage the high drug claims without putting a cap on the annual drug maximums per employee?
Well, it depends. Small plans are almost always insured, so they need to have pooling. But we know that the pooling charges have kind of gone through the roof as well. Small plans are covered under EP3 pooling as well. So there are mechanisms for sure to spread that risk across a larger base rather than just a small plan.
Mm-hmm. Okay. So given the change in cost per insured is around 5%, why do insurers use trend rates that are much higher than when setting premiums?
Yeah, and I mentioned that earlier because the trending is a prospective exercise. I mean, I've been involved in renewals with carriers on the consulting side. It is looking forward. It's not looking backwards. Ours is just a calculation of this 2021 versus 2020. There's a lot of other factors, and it's really the experience of the group, which is not brought into any of our analysis here. It's the book rate or manual rate of the insurer. So there's a lot of reasons why it differs. It's maybe more conservative a little bit, but they're two totally different calculations, which I've been trying to stress every year. Don't look at this and say, well, it's only going up 5%, so why is my trend for next year 8%, 9%? It's really worse. And you look at the size of our book of business, like I said before, 160 million claims. So you smooth out a lot of volatility that would be present in an individual plan, which is what the insurer renewal is based on.
Okay. So we have time for one last question, Shawn. So this question is around your analysis on adherence. How is adherence determined by TELUS?
So what we've used the past couple of years is it's fairly well known. It's a medication possession ratio. So really what it does is looks at the time, the days supply dispensed and the time lag between fills for that certain person for that certain chronic drug. and then just calculates a percentage. So in an ideal world, you get 90 days supply and you'd fill it on the 90th day. 90 over 90 is 1. But often what we're seeing is it's taking the day supply is exhausted long before the next refill happens. So in those cases, let's say the day supply is 90, but the denominator becomes the distance between fills, which let's say it's 110 days, and that calculates you like at 0.08, and anything under 0.08 is considered in an NPR is considered non-adherent. So that's how we measure it.
Great.
And again, it's we never know if the person's taking it on time, right? You know they had it in their possession. That's why it's called a possession ratio. You just don't know. I mean, they could be dumping it down the toilet, and they could be going and getting it filled. So we never know that. That's the limitations with these types of metrics, but they are directional and informative for sure.
That's great. Thank you so much, Shawn. So this concludes our Q&A session. Thank you, everyone, for your active participation and all your questions.